Hello, my name is Dr. Chafic Karam, and I'm professor of clinical neurology at the University of Pennsylvania in Philadelphia, USA. Today, I'm going to talk about treatment advances for ATTRv, a heterogeneous, highly debilitating, and ultimately fatal disease if untreated. ATTRv is a genetic disorder, and the reason we put V is for variant to differentiate it from WT or wild type. And wild type happens in people who don't have the genetic mutation. The disorders do share many of the same symptoms, especially from the cardiac and the carpal tunnel perspective. However, the incidence of neuropathy varies. So, what is TTR, first of all? TTR is transthyretin. It's a protein made mainly by the liver, but also made by other organs, especially in the eye and in the brain. And this protein, as its names indicate, transport thyretin and retinol, which is vitamin A. And in certain condition, especially when you have the genetic variant that is pathologic that you inherit from your mother or father, occasionally it can be de novo, by the way. And when that happens, that transthyretin protein, which is made of four tetramer, it's a tetramer, basically four pieces of protein attached to each other, dissociate, misfold, and when that happens, it tends to stick together and make what we call the amyloid. So it's one of the many subtypes of amyloid that we see in humans, but it's one of the most common, especially in the genetic. It is the most common familial amyloidosis. Depending on what type of transthyretin variant you have, you can have more neuropathy or more cardiomyopathy, or occasionally more rare symptoms like just CNS involvement. And there's over 140 TTR variants that have been described, the most common being V30M worldwide. V122I in Black people is very common. It actually happens about 3 to 4%, and it happens to be the most common variant in the United States. And then there's the T60A, which is the third most common, and that's a mixed phenotype. Patient have both heart and neuropathy, a lot of GI issues and dysautonomia as well. The prognosis of the disease will vary. Obviously, if the heart is involved, then the survival is shorter, about 3 to 4 years. If it's mainly a neuropathy that happens the V30M in the young people, people can live 8 to 10 years and then unfortunately die of cachexia. The good news is that doesn't have to happen anymore because we have a very effective treatment that can prolong life. Yeah, if you think about it, this amyloid is starting to deposit. It's going to deposit in all the organs, but let's say it's starting to deposit in the nerve and it start causing irreversible nerve damage. So if you wait too long, patient going to have foot drop, they're going to have trouble walking, they're going to have weakness in their hands. And if it's untreated, unfortunately, it's going to keep progressing, right? So people end up in a wheelchair and bedbound. Now, if you treat them late, like 2 or 3 years after the onset of the diagnosis, and they already have foot drop, unfortunately, a lot of time that doesn't come back. So the earlier your treatment, the more likely you are to reduce the burden of the disease, the less amyloid is going to be deposited, and the better the outcome. And this has been actually shown in clinical trial when they did placebo versus people taking the TTR targeted therapy. We've seen even in the open label, because at the end of the trial, people switch all to getting on the open label, and everybody got the therapy, even the placebo. In those patients, unfortunately, they did do well, but they did not join the people who were on the drug from the beginning of the trial. So with the deficit that they have accumulated over time, really brief period of time, 1 year and a half, remained. So that's the reason why we are obsessed with finding people very early and starting the treatment as soon as they have any evidence of manifestation of the disease. This is a pretty rare disease and people don't typically think about it. So we come up with what we call red flag symptoms that would make you think that potentially the patient could have amyloidosis. As you know, peripheral neuropathy, there's hundreds of reasons why people get peripheral neuropathy. ATTRv is one of the least common causes. But there's certain things that you can see that can, or in your exam, or when you see the patient, that can suggest neuropathy. So first of all, one of the mostly misdiagnosed is idiopathic neuropathy. You just do your basic blood test. You don't do obviously the genetic testing for TTRV, and you tell the patient, we did everything we can. We didn't find a cause. You have idiopathic neuropathy. So that's one of the issue. Now, idiopathic neuropathy doesn't tend to progress over time. It's you see the patient 1 year after the other. They're really the same. They have numbness, tingling, burning sensation in the toes. Very slowly, it may spread to the foot and the ankle. Doesn't typically cause weakness, etc. Whereas ATTRv polyneuropathy is a rapidly progressive, especially in the non-V122I patients. It does progress rapidly, meaning the patient will develop foot drop. They will develop balance issues and will keep getting worse. Another thing is that it's a multi-organ disease, right? The amyloid is going to deposit everywhere. So any evidence that you have dysautonomia, that you have heart failure, that you have carpal tunnel syndrome, that you have GI symptoms, all of those will tell you, listen, wait, this is not your regular neuropathy. This is a systemic disease. And amyloid is one of the top differential diagnoses when you have something like that. Obviously, if you have a family history of neuropathy, if you have a family history of sudden cardiac death, or cardiac arrhythmia or heart failure, all of those should be really straightforward to make you think about amyloidosis. Another thing that people talk about is CIDP. So CIDP is an autoimmune disease. It's affect the arms and the legs, cause weakness in the proximal arms and legs, and occasionally ATTRv can present like that, especially in more advanced cases, can cause myopathy and people feel really weak. And it may be mistaken for CIDP, and people get treatment. Now, the thing is that CIDP responds to treatment. So if patients don't respond to treatment, then you have to reconsider your diagnosis and look for alternative. And ATTRv is one of the disorder that we need to look at. Yeah, so that's a great question. It really depends on whether the patient is presenting to the cardiologist or to the neurologist, obviously, because from the cardiac perspective, they see findings on the ultrasound, the echo of the heart, on the EKG sometimes, that can suggest that this is amyloidosis. And then they typically have what we call a heart failure with preserved ejection fraction, especially early on. And a lot of time they can start with electrical problem, arrhythmia, atrial fibrillation, conduction block, etc. And those things will make you think about TTR. A lot of time the patient has carpal tunnel stenosis and so forth, or they may even have a neuropathy. And in those patients, what they do a PYP scan. This is technetium-based scan, and they look and it picks up the heart. And if that is positive and you have ruled out another common type of amyloidosis, which is light chain amyloidosis, then you know that the diagnosis is ATTRv cardiomyopathy, or at least ATTR cardiomyopathy, and then you go on to do the genetic testing to confirm that this is. So the cardiac workup is a little bit different than the neurology workup. From the neurology's perspective, you have this patient with neuropathy that it's progressive. You have this autonomia, and you're like, okay, this is suspicious for amyloidosis. What would I do? So then genetic testing comes in play. If you do the genetic testing and you have a variant in the TTR gene, if it's a pathogenic variant, great. If it's a variant of unknown significant, then you have to dig a little bit deeper. Okay. So once you have the genetic variant and you know this is pathogenic, then you have to prove that this is what's causing the neuropathy, because the patient may have diabetes, they may have the B12 deficiency, they may have been exposed to neurotoxic drugs or other reason to have a neuropathy. So you want to try to figure out, is this the cause of the neuropathy? And the gold standard to do that is to take a piece of tissue somewhere in your body and look under the microscope, stain it with Congo red, and see if there's amyloidosis deposition. And once you see that, you send it to mass spectroscopy to confirm that this is the TTR protein and nothing else. Now, things are easier if you go and you find the patient also have cardiac failure, and you do a PYP scan, or even if they don't have, a lot of time it's asymptomatic, by the way, especially in the early V30M, but you do the PYP scan and you find that, yes, the heart is involved. And as we said, we ruled out AL amyloid. Then in those situations, you don't necessarily have to do a biopsy to confirm the disease, because having that PYP scan positive is very suggestive. So these steps that we do to kind of get down to the diagnosis. Genetic testing is very important. Tissue biopsy and the cardiac imaging are extremely important. We talked a little bit about the fact that this is a rare disease, and people, it's not going to be the top of the differential diagnosis when you're thinking about what's causing the neuropathy, or what's causing the patient to have cardiac issue. And we talked about the red flags. So these are ways, raising awareness. What we're doing today, we're giving these talks, telling people, telling our medical student, our resident, our fellows, teaching them, having them see patients. And then when they do that, they start thinking, okay, well, could it be amyloid as well? And, who knows, in the future, maybe everybody talk about AI, and, I'm trying to restrict myself because sometimes it becomes cliche, but obviously that could potentially help us as well in the suspecting the disease and looking for it. So what are the treatments? The treatment rely on two things. You have either stabilizing this TTR protein that we talked about, that kind of dissociate and misfold. So the first step is the dissociation, and the TTR stabilizer, basically what they do, they attach to the TTR protein and make it stable. So they reduce the risk of it dissociating. And then we're going to talk later about what we call the silencers. And these are medication that go directly to the liver and tell the liver to stop making this TTR protein. So the TTR stabilizer and the TTR silencer, these are the two currently available medication. And in the future, we may have different, by the way, treatments that are being currently studied. These medication, the TTR, there's two ones. Is diflunisal, which is off-label in the United States, not FDA approved, but we know that it worked on the neuropathy. There was a clinical trial that showed that it slowed down the neuropathy and improved the quality of life compared to patient on placebo. And then the TTR stabilizer with tafamidis, we know that these improve the survival of patient in heart failure and improve the quality of life. So and reduce the amount of hospitalization due to cardiac failure. So these are great, really treatment. And then more recently, we have a new medication called acoramidis that was also approved by the FDA for the treatment of cardiac disease. So the tafamidis, acoramidis are approved by the FDA for cardiac TTR, whether it's wild type or hereditary, and diflunisal is something used off-label. These are the three stabilizers that we currently use. We first have the first generation, if you want, with patisiran and inotersen. These were the main two trials that really showed that these drugs work. Patisiran is a small interfering RNA molecule, whereas inotersen is an antisense oligoclonal protein that kind of affect the production at the RNA level of the TTR. So when you measure it in the blood, and we can do that, a lot of labs still call it pre-albumin. So we do measure it in our patient, and it drops dramatically after they start the medication. And then there've been a new generation of these medication. Patisiran was IV. You had to pre-medicate. You have to give steroids, antihistamine, and antiacid. You have to sit for an hour. You have to repeat every 3 weeks. Whereas vutrisiran is the new version of this siRNA, and you give it once every 3 months, subcutaneous, and you don't have to pre-medicate. Very safe medication, not a lot of side effects, maybe some local effect. And then with eplontersen, this is one of the improvement on inotersen. You give it only once a month. The patient can administer it themselves. And with inotersen, we have to monitor the blood count, the kidney function, the liver function. With eplontersen, you don't have to do any of those. So the patient get the drug at home and inject themselves once a month. And these drugs have shown dramatic improvement in the patient with polyneuropathy. Not only that, vutrisiran have been recently also approved because it was shown to work on the cardiomyopathy as well. So now in the United States, we are able to use it for both. Remember, at the end of the day, this is the same disease. Whether you're stabilizing the protein or you're silencing it, it's going to work on patients. And then finally, with eplontersen, there's an ongoing cardiac trial, one of the largest in the that has been ever done in amyloidosis. And then we'll have the results at some point in the future, and it could also potentially approved for the treatment of cardiomyopathy. Yeah, so the two main things that are currently being studied are gene editing, mainly with CRISPR therapy, and these are treatment again targeting the liver. The drug will go to the liver, you give it only once, and it basically changes your gene with the TTR expression is only expressed at about 10%. So you have a reduction up to 90% of the TTR, kind of similar of what the silencer do, but this is of more of a permanent and a little bit more pronounced effect on the TTR. And in theory, you just give it once. So this is something that would be even more convenient for our patient, uh, for example. The other things that is being studied right now with, again, multiple clinical trials is the immunotherapy. So these are antibodies that are directed against the amyloid. And the idea is that while we are targeting, we're stabilizing the TTR, we're silencing the amyloid TTR production by the liver, but what are we doing about the amyloid that's already deposited in the organs, especially in the heart and in the nerve? And could antibody that attaches to this and then having your own body with the macrophages, etc., clean out this amyloid be an effective strategy? And we're all hoping that it will be. And that's why we're waiting for these trials to be completed. And then finally, the question is, well, now we have at least two main category of medication, the silencer and the stabilizers that have been approved. Is there a benefit of adding these two medications together? And we don't really have a very good answer. We looked at this ourselves and we didn't really find a major difference in our cohort, although a lot of patients, about 40%, are still ending up on both combination therapy. At least we know it's safe, but we don't know if it really offers additional benefit compared to monotherapy alone.